Good evening, everybody, and welcome to this evening's Pharmacotherapy for Smoking Cessation webinar. We're joined tonight by our two presenters, Dr. Tim Senior and Associate Professor Renee Batoon. Tim is a GP at the Tharawal Aboriginal Corporation in southwestern Sydney. He was originally trained in the UK. Tim is also an RACGP medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health and a senior lecturer in general practice and Indigenous health at UWS. And he's also an RACGP medical educator. And also we have Associate Professor Renee Batoon. She's a tobacco treatment specialist and she has a long history of smoking cessation since the inception of the first Quit campaign in the 1980s. She currently teaches research and is in clinical practice in the field of smoking cessation. She is president of the AASCP, the Australian Association of Smoking Cessation Professional, is the founding editor-in-chief of the Journal of Smoking Cessation, and is leaving on Saturday to take up a visiting professorship at the Sorbonne in Paris. So welcome, Renee and Tim, and thank you for joining us tonight.
Thank you very much. Welcome. Good evening, everyone.
Great. And before we make a start, I just want to make a quick acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. So in saying that now, I'll hand over to Tim to take us through the learning outcomes for this evening. We'll then hand over to Renee to start the presentation. So thanks, Tim.
Thank you very much. Good evening, everyone. I hope we get through a lot of good information tonight for you. These are learning outcomes, which is education speak for what we hope that we'll have covered tonight and that you'll be able to do in your practice tomorrow as a result of this evening online QI and CPD activity. So after this activity, you should be able to discuss the link between smoking rates within specific groups and social disadvantage. Discuss the common barriers and myths related to smoking cessation and understand nicotine withdrawal. Routinely assess nicotine dependence using evidence-based methods and engage patients to manage their smoking through realistic goals and expectations. Discuss the evidence-based smoking cessation treatment options available and where appropriate, adjust drug dosages to be more effective. And provide practical tips related to the usage of the different forms of pharmacotherapy, particularly prescription medication. So hopefully that's all the things that we cover tonight. It's quite a lot there. We've got an hour and we shall try to get you away on time as well. So I shall hand over to Renee. Very big welcome to you tonight, and we're all looking forward to tonight's presentation. Feel free to put questions through in the chat box as well, and we will endeavour to answer those questions.
Thank you. Good evening, everybody. Bonsoir. I'm going straight to the first slide, which is on prevalence of smoking, just to give you an overview of how well we've done in the last few years. You'll all notice, and everybody has, the really precipitous drop in prevalence in Australia today, and in New South Wales especially. You'll see the decline. Since 2016, we've really had some really great news with big drops in prevalence in New South Wales. Of course, the job's not over, and all of us are currently seeing smokers who are really a very different group, a very dependent group, and I'm going to talk about that and how to manage them in a few moments. Just to look at that slide, though, look at the difference between males and females. You can see it straight away. There's an assumption that there are more women than men. That's not correct. You can see there's a big bulge in the ages of, say, 25 to 55, and then there's almost a steep decline. As you age, you're less likely to be a smoker, really, because people who went on smoking died from it. So this is just to remind you very brutally that by the time you're over 75, you're very unlikely to be a smoker. So the prevalence is really quite low. That's a little thing to remind yourself of. There's this quite distinct, almost linear drop from the ages of, say, 35 right down to 75. The other point I want to make out about this slide in particular is what happens when you age. And I don't want to, I guess, marginalise the men, but what happens with age is there's less reinforcement, there's less reward. there's less drug reinforcement with age. So I want you to remember that. There are spontaneous quitters. People who age tend to not the aged don't take drugs as readily as the young. We all know that, but keep in mind there might be a neurobiological aspect to that. The reward isn't as great as you age. So they sort of spontaneously, there are spontaneous quitters of other drugs as well, not just nicotine. So I just wanted to remind you of that as we go forward. Something happens when you get older. And it's not older and wiser, but there is this peak around the young, and probably because they get a great deal of neurological reward from smoking. So who is still smoking? People who are highly dependent. We see that all the time, and I'm going to tell you how to or show you how to measure dependence. People with mental health problems. Are they self-medicating with nicotine? Have they always had mental health concerns? Have they always had depression and they're masking it by smoking? That's a really strong possibility. Obviously, there are drug and alcohol comorbidities. Do people who use other substances smoke as well? The principle, for those who are thinking about it, is almost 90% of other substance users and abusers are smoking as well. Are there concomitant benefits to do that? Does nicotine enhance or other substances enhance each other? Do they have synergistic effects? They do, so do keep that in mind. That may be why they're smoking as well. We had a question about marijuana smoking already straight up, and yes, this relates dramatically to marijuana smoking. What I will tell you and talk to you about, there's a lot of interactions, and so once people stop smoking, they tend to drop the other drugs as well. Don't be surprised. So it may go the other way. We may be able to address smoking to address their other drugs. I'll keep you posted on that one. People who smoke with diseases related to their smoking, so if you've got patients with COPD, with coronary artery disease, with cancers, don't be surprised if they smoke as well, or they continue to smoke despite these. They can barely breathe, they smoke anyway. That defines them as addicted to smoking. That's a definition. I can't breathe, I've got asthma, I've had coronary artery disease, I've had my stents put in, and I'm still smoking. That's a patient who is unfortunately very significantly dependent. So keep that in mind. Don't always go, you mustn't quite understand the repercussions. They quite fully understand the repercussions. They do it anyway, and that's what addicts do, despite the consequences. They've tried multiple unsuccessful attempts. Don't go down that road thinking they're not motivated to quit. They are. People who are highly addicted need extra help. They're not terribly, unfortunately, very successful at doing it because they're highly dependent. They do have, because it is a socioeconomic concern, many life stressors. It's not like they don't have them. You and I can manage or deal with a big phone bill, for example. Our smokers today, with other comorbidities, with drug and alcohol concerns, with mental health concerns, can't pay that bill as readily, become more distressed by it, and unfortunately resort to smoking to manage or to self-medicate their anxiety. We also have a group, I'm sure you all know, higher prevalence in our Indigenous populations, and that's an unfortunate circumstance. More remote the communities are, higher the prevalence is, and that's brought together really with the socioeconomic status of our Indigenous populations who are living in remote areas, and also the culture of smoking. There are townships where just simply everybody is smoking, and other townships where nobody is. So the culture also has a strong impact in this as well. What we know has helped drive down the cost. I'm just going to say that, the cost of smoking. For those who don't know, I'm interested to know how much a packet of cigarettes today. That is a legal packet. Do you know the difference between a legal one and an illegal one? I'm just interested to know, does everybody know how much it costs now? Just your average let's just say the most popular brand might be Benson and Hedges, might be an ultra mild cigarette, which, by the way, ultra mild is not better. We would never recommend a mild. So how much does it cost? Do you know? Should you know? Well, yes, you should know, because it costs round about legally $35 a packet. And there's going to be ooh and ah in the audience of people who don't know that. You should know how much it costs. So stand at the checkout next time you at the supermarket and see somebody buying a carton. Could cost them $250, a carton of cigarettes. And if you didn't know that, now you do know why some of our patients are spending a good part of their income, a good part of their pension, a big part of their pension on tobacco. And it's always the highest priority. I'm sure you know that. So, but the increased cost has driven smoking down, and it's by far now today the number one reason why people want to stop smoking. It doesn't mean they achieve it, but it's number one on their list. Health has now gone to number two. Number one is, I don't want to do this anymore because it costs so much. There's nowhere to go to do it. You probably all know that. So having venues where you can't smoke is terrifically important. It changes all the dynamics, the cues, the cue conditioning reactions you get. So venues where you can't smoke actually are helpful for our smokers. They're not as likely to smoke where you can't smoke. They don't break the law. You don't see people getting on a bus and lighting up a cigarette. They actually compliant with this. So in case you think it's a bit draconian to have, no smoking everywhere, it's actually very helpful. The graphic warnings on packaging, I'm sure you all know, they're changing the warnings, routinely rotating them. This is very impressive to smokers. They are impressed by that. And interesting enough, the brand is very small. The brand name is very small on the actual package. So they don't recognize their own brand as well. So that's also helpful, because brand recognition triggers off an urge to use. So that's just another side issue about the graphic warnings that really is very helpful. We know all the marketing campaigns out there, all these things, this is a drip effect. You don't have the product available to you. You don't see it available to you. There's restricted sales to minors, and that's enforced. There's advice from yourselves. We're getting increasingly, our clients and patients are very well aware of the medical consequences of smoking. Literally, blind Freddy should know the impact of smoking on your health. And of course, our pharmacotherapies, unlike many other countries, our pharmacotherapies are heavily subsidised. Remind yourselves that every single smoker, doesn't matter who it is, you or me, is entitled to a subsidy. It's not means tested. It's not healthcare card carriers. Everybody. So our governments are very supportive in helping subsidise our patients to quit. It's in their interest to do that. So we know that. So what is a barrier? What's happening to our smokers who want to do this and can't really get over the line? They're obviously very much addicted to this. This is not easy to manage for themselves. It's not really a choice they're making. Now, there's good evidence to say that people find it very difficult, that they're not choosing to smoke. Their motivations aren't really poor. What's going on is the drive to use the drug really overwhelms them. And if we had time tonight, I'd show you some lovely neurobiology about this. This is called corruption of the neurological connections for you to make reasonable choices. Unfortunately, that's what happens with drug addicts. They do what they shouldn't do in the face of what they know to be conflicting imperatives. So they've got these conflicting drives. They love smoking, but they shouldn't do it. They love it. It's too expensive. So they're very confused with I need to smoke, with I love to smoke. I love doing it, but I hate doing it at the same time. All this going on in the same head of the smoker. There's of course a fear of failure, and they've had many of them. They'll often know somebody who's quit smoking either spontaneously, could be their partner just stopped like that, or using one patch and gave up smoking. What's wrong with you? You mustn't be mustn't be strong, your willpower must be really weak. None of that is true. Don't blame the smoker, but they do blame themselves because they hear from around them other people who have quit successfully, spontaneously. So there must be something wrong with them, which there is, but it's called nicotine addiction, which is actually a significant problem. They might be using other substances that actually interact, and I'll talk to you about that a little later. Other substances like alcohol in particular and caffeine in particular, and I'll mention that in a little while, why these things actually interact and have synergistic effects and make it difficult for them to stop. Living with a smoker, having other smokers around you, I mentioned the culture around you. If there's a lot of family members, friends are smokers, and it's the norm, you see that as what other people do, and reminding yourselves, I want you to remember that other people's cigarette smoke itself is a trigger to smoke. You simply breathe it in. This is not like alcohol, which doesn't jump from one glass to another. If you're having water and your friend is drinking, you're not going to be a passive drinker. But if you're a passive smoker, unfortunately, when you're trying to stop smoking, that's nicotine entering your bloodstream. We can measure it. So keep in mind, other people's cigarette smoke has other components to it, not just seeing them doing it, but actually breathing it in and inhaling it, and that becomes the trigger. It's like a little bit of alcohol for an alcoholic. It's not on. So we've got to teach smokers what to do when other people are smoking around you and you're trying to quit. It's a barrier to helping you quit smoking, so we need to address that. The other thing that's very interesting of late, it's been fairly newish data coming out, that nagging, we sort of knew this, didn't we? Nagging by family, nagging by friends, nagging by your GP turns the patient off. We've got to have a better way of approaching it, something a bit more sympathetic, understanding that they're dependent. Nagging it actually not only is a turn-off, but can be, unfortunately, a trigger to smoke more. People get very agitated by being nagged and go away and smoke. And agitation or distress by being nagged, or literally somebody else being aggressive about your smoking, actually puts you off. And I wanted to remind you of that, to take a softer approach and perhaps a bit more sympathetic approach to your smokers. The hardest quitter is the one who wakes up within 30 minutes and smokes straight away. You've heard this question already. I hope you have. It's called time to first cigarette. Of all the questions you might ask your smoker, it would be the most important one. It's a giveaway. I wake up and I need to smoke straight away. Why do you need to do that? Think liver metabolism. Don't think they're weak or this is a bad habit and that's what they do. They wake up because they're practically metabolized a lot, and fast metabolizers do that. I'll tell you in a moment about fast metabolizers, but think of the question to ask your smoker now that you didn't know before. When you wake up, how soon do you smoke? If they do it almost immediately, that's a giveaway for a heavily dependent smoker, really, and a fast metabolizer. We talked about this earlier. They've tried before to stop smoking and they haven't done well. That really is a giveaway too of a heavily dependent smoker who's got a lot of symptoms of withdrawal, which I'll talk about in a moment. And for example, and give this a thought, how many smokers do you know who've used NRT and smoked as well? They haven't overdosed, and they don't. And let me tell you now, straight up, they won't overdose. It just simply means their blood levels of nicotine are higher than the average smoker, and they're getting withdrawals either on NRT or smoking at the same time. This is a person who's heavily dependent and needs more NRT. Simply a symptom of underdose of NRT, not overdose, but underdose. So keep that in mind. These are people who've been trying. They're not weak-willed. They're not motivated. They simply had really poor experiences in the past trying to quit smoking. And poor them is all we can say. A bit more sympathy to these poor people. And as I said, they're likely to be fast metabolizers, and they're doing something about it. They're just not getting very far with it. I mentioned fast metabolizers, and I want you to think about this. This is a liver enzyme function, P450 system. CYP2A6 is the enzyme that metabolizes nicotine, and there's a range of 2A6 from slow to fast metabolizers, and you're born with that. So this is a genetic predisposition. You can't do a thing about it. You can up manipulate, if you like, or instigate more to A6. But basically, the type you're born with is the type you're born with. And I wanted to point out something. I'm looking at the list of doctors whose names I'm reading here on the list, and I notice many from different countries. I want to point this out to you if you didn't know this before. Some of your patients are fast metabolizers. Some of them are slow metabolizers. Who are the fast metabolizers? If you don't know this already, you can look this up, but it would be your patients from the Middle East. I can see there are people from the Middle East. Think about it. Are they smoking a lot of numbers per day? They are. Fast metabolizers smoke a lot of numbers. They excrete nicotine quickly. They get up in the morning and it's number one thing they've got to do. So do keep that in mind, who they might be. For those who are Caucasians, they're in the middle somewhere. They're also faster metabolizers than Asians, Southeast Asia. Think about this group. Think of your Japanese, Chinese, Southeast Asians. They may smoke. Interestingly enough, there's the prevalence of smoking might be high in this group. Think about that. But the numbers they actually smoke and the manner in which they smoke is very different. Think about, do they get up and smoke straight away? Probably not. Some of them do, some of them don't. But do think genetic differences. So if you're thinking of your clients from the whole of the Mediterranean rim, anybody here thinking southern Spain, southern Italy, southern Greece, Turkey, the Middle East, North Africa, if you've got patients from there, they're fast metabolizers of nicotine and they smoke a lot. Even the women who don't smoke a lot, as in percentage, but when they do, they smoke a lot. So keep that in mind. They're going to need more NRT. They don't do well on one form of NRT. They're going to need multiple forms. They inhale deeper. So I want you to think risk of lung cancer is related to how you metabolize nicotine. It's complicated, but think of that. They are at higher risk of that as well. So they're going to be doing more numbers per day, and they're going to be smoking, inhaling deeper than the slower metabolizers. So keep that in mind. I think it's a very interesting point you may not have heard before. The other liver enzyme effect that is dear to my heart, and I talk about every time I talk about smoking, and that is the smoke itself contains a chemical. It's in gas phase. They're polycyclic aromatic hydrocarbons. Some of you have heard of this before. You might know what it is. It's the charcoal on your steak. You're not supposed to eat a lot of it. I'm sure you know all that. You've heard this all before. But that actual chemical, when you inhale it in gas phase, induces, that's the term, induces the liver enzymes as well. In particular, liver enzyme 1A2, which you may be interested in knowing, metabolizes caffeine. Now, if you ever care to ask, and we always do, and I want you to be aware that there's a website now, the college has a website with all the medications that are involved, but particularly dear to my heart is caffeine and alcohol. What happens with smokers is they tend to drink a lot more coffee, and most people don't think twice about it. Now you will always ask your smokers how much caffeine do they use, and that includes all caffeinated drinks, and you'll be astonished to hear 5-6 cappuccinos a day, and that might include Coca-Cola, Pepsi-Cola, Red Bull. Ask them how much caffeine they use, because these PAHs will induce this liver enzyme 1A2 such that most smokers will need to drink 2 or 3 caffeinated drinks for every one a non-smoker has. So remind yourselves of that. Ask them that. What happens then if you don't smoke anymore? You can become caffeine toxic. This is not a small matter. They'll tell you, I've got the jitters when I try to stop smoking. These patches are keeping me awake at night. Common comment. Patches are keeping me awake at night. This is not common at all. This is not patches. This is caffeine toxicity. It's a common problem with when you stop smoking. And it's not the patches that are doing it, and it's not the Champix that is doing this. This is actually the caffeine. Alcohol is the same. Unfortunately, smokers drink a great deal more alcohol, and you'll know that's why the pubs want you to stay smoking, because you'll drink 3 times more. Again, this is because because these PAHs and nicotine also in this case induces alcohol dehydrogenase. And I want you to really think about that. These interactions are not just synergistic in the brain, but they have liver enzyme interactions. There are many medications you need to be aware of. If you're not, shame on you that you don't know that clozapine is affected by smoking, that olanzapine is, that is warfarin is. We also know that methadone is. Painkillers are. There are many medications that are affected by smoking. Most of your patients will need higher doses to get the effect, the positive effect of their medications. And when they quit, you will need to reduce the dose. So I'm being pretty quick about this, but do look this up. It's accessible to you. Okay, so what do we say about smoking? We always ask about smoking. I'm sure you all know that, but remind yourself to ask about caffeine and alcohol, and remind them why they're drinking so much coffee compared to you, a non-smoker, why they need to. And it'll be cheaper once they quit smoking, because less coffee, less alcohol you need to buy for the same blood levels. So remind them to reduce it. We always say reduce, certainly the caffeine, and adjust their medications. Keep that in mind. Assessing a smoker, I talked about time to first cigarette, which is very important to ask. Ask them about their pharmacological failures. Ask them about their quitting. Ask them about family history, because that's the part of that heritability. This liver function thing is an inherited trait. There's smokers breed smokers. Unfortunately, heavily addicted ones do as well. And haven't got time to talk about smoking in pregnancy, and those who are logged on know all about this, but you can pass on nicotine addiction. It's an inherited trait. Remind yourself of their medical history. Psychiatric patients who need to smoke, maybe self-medicating, have high levels of nicotine in their bloodstream. I want you to think about daily smoking. Don't be so fussed about numbers of cigarettes per day. Do keep in mind people who do cut down might smoke differently, inhale deeper, titrate or compensate for smoking less by dragging harder, and their carbon monoxide levels go up. So the things we wouldn't really recommend is lowering the nicotine content of your cigarette. A weaker cigarette is not a better cigarette, is distinctly a worse cigarette, because you have to inhale deeper. And that if you ask them to cut down, they will smoke differently too, and their carbon monoxide levels will go up. And that's why we recommend carbon monoxide measurements all the time, which we do. I just want to remind you about what nicotine withdrawals are, and reminding yourselves that this, I have seen this since the 1980s, way before the advent, well, before I even had NRT in my hands. No gums, no patches, we had no Champix. People became, when they stopped smoking, irritable, anxious, distressed, depressed, couldn't sleep. I want you to think about that. This is way before the advent of any of, don't assign these side effects to overdose or a medication side effect. Classic one is Champix. Don't go, my patient is depressed because they're on Champix. Wrong. Think depression because you're not treating them well enough for their withdrawals. So the Champix isn't doing it. You might have to add NRT. I'm just giving you a little hint here. Please keep that in mind. So our talking points for yourselves is don't be judgmental. Don't nag the patient. Inform yourself about the biological basis for smoking and nicotine addiction, and inform them, because the more they know, the better they do. They know that. We know that. We don't say people fail. You haven't done. People don't want to be competitive. Do remember people don't do well. We talk about managing your smoking. It is complex. I'd like to manage it better. You want to manage it better. And remember, their motivation vacillates. And do keep in mind, it's not one size fits all treatment at all anymore. It used to be, you'd wave your finger and say stop smoking. Now we don't. we know that there's a variety of things that suit some people. How they metabolize this drug matters a lot. So we know that counselling helps, we know that pharmacotherapies help, and we know that the quit lines help. We know to combine all of these things together to give your patient the best outcome. Again, without nagging and being a great deal more sympathetic. So I want to remind you there's no scientific evidence to support hypnotherapy or acupuncture, psychotherapy. This is all for quitting smoking, maybe for other things, but not for this. Negative affect counselling, meaning stress management. There's no evidence. We love it, but there isn't. These self-help books, you've always got somebody who knows somebody who quit using them, but we've not really got the science to support any of these. And the trials have been done, so don't think they haven't. They have. So there are a lot of things. Remembering that cutting down might not be helpful, and that weaker and milder cigarettes might be worse. So we wouldn't recommend to support any of these as strategies at all. The pharmacotherapies, we know the first-line treatments, and I would like to say I declare I have no conflicts of interest. I do not work for the pharmaceutical companies, nor do I work, evidently not, for the tobacco companies. But I just thought I might mention that, no conflicts of interest. So, and I'm not on any of their boards. So I can strongly recommend NRT and a lot of it. A lot of it. We grossly underdose our smokers with one form of NRT. Combinations are much better. Champix, varenicline alone, all combinations with NRT are great. Zyban, bupropion alone, all combined with NRT. So combinations are looking better and better in our more difficult, if you want to call them, recalcitrant smokers. We do use nortriptyline, anxiolytic nortriptyline, naltrexone. They're not registered for use for smoking cessation, but they are used, and some of you might have used them in the past or currently. Combining is if it were me, I always say if it was me, if I was trying to stop smoking, I'd probably try Champix first, see how I go. If it's great, I'll use it. If it doesn't work, don't blame the patient, move on to something else. So what's the right pharmacotherapy? If they've used Champix before and it hasn't worked, don't bother this time, truly. If they've used NRT and it hasn't worked, get out some more information, find out what they tried. It's usually underdose. Major problem is underdose. I want to remind you one other thing. Women metabolize nicotine faster than men. Look at how their past outcomes have been and remind yourself of maybe not using it correctly. Sometimes that's the problem, but mostly it's underdose. I just want to reiterate that obviously today. So with NRT, obviously we don't see any side effects. I have never seen a case of a nicotine patch addict on the planet, and I read a lot on the topic, never seen nicotine patch. We also don't see nicotine overdose, so don't be fearful of overdosing people. They don't overdose. Is it safer to wear a patch and smoke at the same time? Yes, it is. I'm just telling you this right up front because I know I'm very pressed for time. I want you to know it's approved by the TGA, NRTs in pregnancy. What we find in pregnancy is that women metabolize faster and need often to use more NRT. Be aware that I recommend patches over other forms of NRT. Simply they put it on and that's the end of the compliance. If you're going to use gum or lozenges or anything else, you really need to use a lot of it, not a little bit. 25 cigarettes a day, 25 gums a day. And now, would you do that? Probably not. So the idea is a lot of it. Patches and gums at the same time is probably better. There is no evidence to support going down from 21 to 14 to 7. There never has been. We wouldn't use anything weaker than a 21 milligram patch. There's no evidence to start on lower doses. Don't do it. Lower doses, for some reason, historically were developed, but myself and colleagues all over the world know there is no evidence to start anybody, especially not you smoke less, you'll need a weaker dose. There's no evidence for that. Don't do it. Pretty straightforward. So just to remind you, plasma levels of nicotine are pretty low. I want to point out on the left-hand column the x-axis, the nicotine blood levels in smokers is in nanograms, not in milligrams. Nobody ever gets 21 milligrams from a patch. You die. 1 milligram of nicotine will kill you outright. So obviously we're not delivering these doses to patients. It's very, very weak. So just to point out the red on the red line across over time, this would be a nicotine patch, very slow, very low. Look at the levels, look at the smoker's level, look at the patch level. That's why we do these combination treatments. I want you to have a good look at that and remind yourself of that. We're underdosing smokers. We're not giving them what should be called nicotine replacement therapy. So avoiding underdosing, combination treatments. We do carbon monoxide monitoring for feedback all the time, and it's a great motivator if you can do it. We don't recommend stopping too early. We do NRT for 6 months, ideally. If you can do 6 months, your smoker will have changed, not just the manner in which they've smoked right in the beginning, but absolutely the nicotine receptors in the brain, for those who know about them, down-regulate. In other words, it's less nicotine receptors being produced as you, cut down smoking with NRT and then stop. So the longer you do this, the better. So longer, better. Higher doses, better. So these are these harm reduction strategies that I really do want to remind you of for your difficult patient who doesn't want to stop, who's not interested in quitting. No, don't even go down using the word quitting. Tell them you'll do less harm. You will do less harm. You want to smoke, fine. Put on a patch and smoke anyway. That's what I tell them. And off you go. And then I might increase it. I might increase it for another patch. We use multiples. We for those who don't know this, multiple patching, lots of nicotine replacement therapy, all going on at the same time. Mix and match. It's fine. Patients do not overdose. You can't dispatch a patch wearer. Got it? Okay. Little joke. And I wanted to. The benefits of this is that smokers realise they can wear a patch and they can manage their smoking, and it's not like a hard thing to do. So if they're doing that, in fact, encourage it. It allows them to gain a bit of autonomy over their smoking, and they're not aware that they can do this, that it's safe to do this. Absolutely. And I want you to encourage your difficult smokers that this is safe to do this, and they won't compensate their smoking. So if they're going to start smoking less, which they sometimes just spontaneously do because they're wearing a patch, so you don't tell them to quit or stop or cut down or anything. They just stop, don't smoke as much. And when they do that, you'll notice they don't compensate. They don't drag harder on a cigarette because they don't need to do that. And just reminding yourself that there's no fear of overdosing, and in fact, the addiction actually starts to go down, go away, which is great. They may not know that or understand it, but you do. So this is a quick case study of somebody whose carbon monoxide levels I measured. This is somebody uninterested in quitting. No way was he interested in it. He tried other substances in the past. He was that is to help him stop smoking, and it didn't help him. He tried, and he hadn't tried NRT, but he was a significant alcohol user and he was underweight. He came in with an acute exacerbation. Carers brought him in. He was in a facility where you're not allowed to smoke. They're fairly draconian there. They're saying, you're not allowed to smoke. He had an acute exacerbation of COPD, and frankly, the facility group there said, that's it. You've got to stop smoking. And they were on his case. Every minute he lit a cigarette, they were on his case. So I'm not quite like that. He smoked 50 rollies a day. No evidence that rollies are any better for you, green or herbal or anything. You'll know that. You inhale, you're going to have higher carbon monoxide because you roll your own. So never recommend that ever to a patient. So I said to him, look, his carbon monoxide was 30. How about you wear a patch and smoke anyway? So the carer with him went, oh no, he'll overdose. And the thing to say to the carer and the family is, no, he won't. It's really safe. It's fine. I recommend that you do that and put it on just before you go to bed at night. And the point of that is, if you remember that graph where the blood levels are very slow with patches, putting it on just before you go to bed at night, ironically, saves the people from nightmares at night. And when they wake up in the morning, they have a reasonable blood level. It's not great, a reasonable blood level of nicotine to wake up with. So the time to first cigarette changes. And it changed everything for this man. He's a typical case. He came in the next week saying, I only smoked about 20 a day. I wasn't forcing myself. I don't want him to force himself to not smoke. You smoke, you smoke. Fine. Comes back and it's gone down to 21 parts per million. His CO levels dropped hugely. This is his own. You know, it's a bit like measuring with a breathalyzer. They're chuffed. They think it's fantastic. And then I add another patch. Like, can you do that? Is it safe? Yes, you can. Can you smoke as well? Yes, you can. Off he goes, and he can do all of this. And he comes back smoking 8 a day and 10 parts per million. Fantastic. Next time I add another one. Now, no overdose here, folks, so don't be worried about that. What we do is we're giving him the right amount of nicotine replacement therapy. His flag for me was that he had a history of alcohol abuse. Usually, any drug and alcohol user, anybody with mental health disorder, they're going to have a higher level of nicotine replacement required. Their blood levels of nicotine are higher. So that's a flag for me. And he smokes in the face of his COPD. So all of this tells me high levels of nicotine. Give him more, not less. And I then weaned him off his patches in reverse, and he stayed on one patch more than 3 months. He remains a non-smoker, really chuffed, didn't have to do anything, didn't have to force himself, go through withdrawals or anything. And that's really the strategy we're using today. Just moving on to Champix while I can. It is currently the best odds ratio for helping people to stop smoking. If it was you and me, that's probably what we'd try better. It depends on your age. I might add a bit over that age group now. Interestingly enough, we know younger seem to do better on Champix. This is a recent finding. Also that women do a tad better than men. These are also fairly recent findings. And I just wanted to suggest that you try it out. You do better if you stay on it longer, but not everybody does well on Champix. So we have a certain criteria, really a strategy, if you like. I've developed a little flow chart, for deciding on who's going to be on Champix. For those who know, this is a slide on the safety issues. If you're concerned about Champix, we're not particularly concerned at all. We wouldn't say there was any exclusion, except really in pregnancy. If any of you have looked through the safety aspects of this, we've got the EAGLE study. We know the colleges have actually put together quite a nice report on this, just for you to look up. So we're really not concerned. There is a lot of, I guess, bad press. Keep in mind, I have no connections with the drug companies that make this. I just want you to be aware, remembering that we've seen patients with these symptoms of withdrawal before we ever had Champix. We've seen that we can manage it better if they're symptomatic, but they're not smoking, for example. We would add NRT, and I'll show you that in a flow chart in a second. So we can actually combine treatments with all of these things and do better with our outcomes. So I just wanted to tell you not to be concerned. There is a lot of bad press out there, not really valid at all. You know that a lot of people on Champix do become nauseated. Remember, it's really poor usage themselves. 35 to even 40% say nausea is the major side effect for them. Reminding them to take this with food. I tell them with food, and for a smoker that maybe a cup of coffee for breakfast. That's not food. You've got to have something in your stomach, and we would suggest that you have it in the middle of your breakfast. It's like giving a tablet to a dog in the middle of it, not after it, not before it, and not on an empty stomach. If they have sleep disturbances, and this has occurred with some of your patients, the 8-hour difference between the first tablet and the second, bring it on earlier. Bring it on a bit earlier. And just to remind you, you don't have to set a quit date either with Champix. We learned this almost immediately, I have to say, with it. We learned straight away that people had a delayed response. So it might not be, quit on this day. Don't pick a quit date. I tell them a quit date will pick you. if this works within about 4 to 6 weeks of using Champix, they'll get the notion that it's less and less interesting. It's no more rewarding as it used to be. I'm smoking less of the actual cigarette. Things are starting to change without them having to force it. Don't force it. It'll come to you. As I said, a quit date will pick you, and that's usually how I like to address it for them. If it doesn't, don't panic. Move on. This is my little flow chart about it. It's very new to me. I've tried to put together what we might do for prescribing or recommending Champix. I said it'll pick you, the quit date will pick you. You might, if it has no effect, you see on the right-hand side, if it has absolutely no effect and they're still smoking exactly what they ever did and they're loving it to bits and it's still exactly as rewarding as ever, move on to another pharmacotherapy. It's not going to work. And it's not the patient's fault. Don't go down. It's got to do with the receptors, brain receptors, subtypes. They've got these nicotine acetylcholine receptor subtypes, which is genetic, about which you can do nothing. So there are a proportion, probably 1 in 3 smokers, who will not get a response to Champix. Don't blame them. Move on. If they do, you've got this choice whether you can either go on for the other scripts or add NRT as well. So we do that very commonly now, very commonly. I know there is a cost involved here. Not everybody, of course, gets all the subsidies for all of it, some of it. So Champix is usually the best choice to start with. A little bit about Zyban. It was originally an antidepressant because there was this finding that suddenly people were doing well, stopping smoking spontaneously, who were being treated for depression. So that's very interesting if that's how this came about. It used to be called Wellbutrin, if you didn't know that. But it's the liver enzyme, again, a subtype 2B6 metabolizes bupropion to its active ingredient, hydroxybupropion. Again, you may not have known that. If you don't know that, it's why some people do well on Zyban and some don't. And the ones who don't probably haven't metabolized it correctly. And that's not their doing, it's genetically determined. Not much you can do about that. Reminding you that there are contraindications like seizure threshold. Some of you have heard a history of epilepsy, fitting and fainting. There might be drug interactions with Zyban. So it's not as widely used and certainly not as good as varenicline. So we tend to be not using it as much as we used to in the past, or recommending its use, or recommending GPs prescribe it as much. But still, some will see that they've done very well. Okay, just moving on to e-cigarettes, because I know there was some commentary about this. I'm sure you know that this is very controversial, and the effectiveness as a cessation aid is very limited. And we now even see that it may be an instigator in young people to go on to smoking, so that they may initiate on e-cigarettes and flavoured e-cigarettes and then go on to smoking cigarettes. So this is a very very effectively diversive in the tobacco control movement. I think the tobacco industry would probably be thrilled to bits. You probably all know, I'm assuming you all know, that nicotine comes from no other source but the tobacco plant. And who owns the tobacco plants but the tobacco industry? So I personally am very opposed to e-cigarettes. You obviously can make up your own minds about it, but I think there's really no evidence to support scientifically yet that it's safe or a suitable quitting aid. Is the handling and the holding of cigarettes, that sort of analogous cigarette, is there something that might be there? It may be, but really I believe it's the cigarette of the 21st century. And as I said, I think the tobacco industry is delighted. I wanted to remind you that you can refer to the quit lines, and the quit lines staff are very well trained in smoking and smoking cessation, and have learnt a great deal more for those who know about this, about some of the topics I've mentioned tonight, drug interactions, metabolizing nicotine, and are very, very effective in helping you. So there is a way of, as you know, of ordering quit line referral forms. And the next slide, just to remind you, what to say to your patients. Your role is huge. I think we've now learned not to wag the finger anymore, to show empathy to our smokers, to dispel some myths and misconceptions. There are so many out there. We don't want to, the healthier cigarette, the milder cigarette, the roll your own. You've got to dispel this myth and reminding your clients or patients why they're doing what they're doing. I did want to mention something quickly about carbon monoxide and cannabis for the question that came up really earlier. A lot of nicotine in people who smoke cannabis mull that's the term for it, I believe, mull their cannabis, they mix it up with tobacco, not just to thin it out, but to make it more inhalable. They tell you it's harsher if you if you take away the tobacco. Straight marijuana, smoking it, makes you cough. I want to remind you, if you didn't know this already, evidence to support this, that nicotine actually is a cough suppressant. And that's why most smokers don't cough when they're actually smoking. But as soon as they quit, they get a cough reflex back. So if you've got a smoker who says, I've got a cough now that I've stopped smoking, you're right. That's absolutely correct. They'll be coughing up phlegm, and that's a good sign. It won't go on indefinitely, but it's a very good sign. Now, your marijuana smoker is using that mechanism of suppressing your cough by adding it to their marijuana. So one of the ways, and remember, nicotine is very addictive, that we get people off marijuana is using NRT to help them get off the marijuana. There's even evidence to putting them on Champix might do it too, simply because their interest is in the nicotine. They're dependent on the nicotine and they don't know it. Remember, they've also got that caffeine interaction too. So I want you to remind you of those things, to understand the liver interactions with smoking. Remember the caffeine, remember the alcohol. It's not a glass of milk and a cigarette, is it? It's not an orange juice and a cigarette. It's alcohol. It's caffeinated drinks, particularly because of those interactions. Keep those in mind, the synergistic effects in the brain and the liver reactions. Put your smokers in touch with the quit line, and for yourselves, be better informed, reminding yourselves of these or learning hopefully potentially for the first time some of these aspects I've been talking about tonight. Reminding your patient is chronically dependent. This is an illness like all the others. That's why people relapse. This is a chronic relapsing disorder. This is not something that's just going to go away. People do relapse. They're not weak-willed. This is what illnesses are like this. This is what happens with your diabetics. This is what happens with your patients with chronic respiratory illness. We're trying to find a cure, and we're working very hard at it. Reminding yourself that this treatment advice is not a one-size-fits-all anymore. We've learned that a lot. There are different smokers. They have different ways of nicotine in their bodies. Pharmacokinetically is different. It's not the same. If you can use a medical model for yourselves, it'll be so much better. Please consider these harm reduction strategies because they're safe and our patients love it. We've done studies enough to show that they like this strategy. Everybody wants to quit smoking, but they may not want to do that today. Do they want to cut down? Yeah, they do. They want to do that too. So how about this strategy? You can do this as well. All the tips you give, please base it on evidence to support this. And please remind yourself that their environmental cues are really very important in all of this. So if we can have our moderator.
I was going to pose the question to you that's come through from a lot of people about using carbon monoxide monitoring and how GPs can do that in their rooms.
Look, I think it's the equipment. For me personally, it's the equivalent of a stethoscope for people who are cardiologists. People measuring blood pressure. You can't live without it. I personally can't live without mine. It's not cheap. So it depends on how you view this. It's about $1,000 to buy. There are some on the market in Australia, and there's even some that you might know about that actually do an extrapolation and measure or extrapolate to fetal carboxyhemoglobin, which is incredible because the mum doesn't realise that the fetus has got carbon monoxide as well. So you can buy these pieces of equipment. I think it would be wonderful that the GPs have them, and some of our GPs do, and they absolutely swear by. It's a motivational tool, and as I showed you in that case, It's not just a motivational tool. It actually shows them reductions as time passes. They're thrilled to bits to see a personal reduction. Warning a smoker that they're going to get sicker or it's impacting on their health may be one thing, but here you've got this direct response to their smoking today, which is really very, very good to do. So that's how you can measure carbon monoxide levels. But you need to buy them either.
And I presume there's no Medicare rebate for doing it.
I'm afraid not. We have tried. If all of you can come together, pull together and do this, it'd be great.
Yeah.
When you think about it, I mean, it's rather shameful, isn't it? This is the most likely cause of death of any of your smoking patients. Of any of your patients, really. Smoking is the most likely cause of their death.
Yeah, absolutely. And all the devices on the market are reliable and similar. There's not one that's better than another.
Yes, correct.
One of the other questions that's come through a few times is about combination tablet treatment. So using combination Champix and Zyban, or using combination of, say, Champix with an SSRI to treat people's depression.
Absolutely, all of the above. Very fun, safe. There is this myth out there that you can't combine SSRIs. It's a myth with Champix. That's just not correct. You can literally prescribe anything with Champix. There's no contradiction with any medication at all. None.
Because I think that'll be something that's very commonly seen in general practice, is a combination of those.
You get these concerns and warnings about depression and anxiety, but you get that if you look up NRT as well. If you look all up, the pharmaceutical companies will often say, caution with depression and anxiety, or suicide ideation. But I think we've clinched it now that there's no evidence to support that one particular thing is more causes more than the other. So there's good studies that show NRT equally the same as Champix. I'm afraid. Yeah. It's a big rumour that's been going on far too long, and to our detriment, because Champix works, and again, I've got no conflicts of interest at all.
Excellent.
A weekend smoker? Well, ironically, you do get thank you very much. These resources are great. The weekend smoker is the Friday nighter who, I've had a patient who only, when she drank, she smoked. She said, I can't help myself. It's out of control. What'll I do? And I put her on a patch just on Friday. That's it. Put her on in the morning. It peaks at night. Took care of her urges to smoke when she was drinking. Social drinker with her friends, doesn't want to give up her social drinking, doesn't want to give up her lifestyle, which is, you don't really want to say, okay, don't go to the pub ever again, which would be the alternative. So we do know that, if you can treat it like that, she really had overwhelming urges to smoke every time she was drinking. And now she's not on patches anymore and she goes to the pub and has a drink. So there you go. You can treat it just for the one day. I do want to point out you've got in front of you these resources New South Wales Health has. Please look at them. This particular pages, you've got toolkits, page 6, page 7 is just shown to you right on your screen. New South Wales has that. You can access that. It's terribly important, especially about medications. There are algorithms in there about how to use NRT, how to add NRT. There are flowcharts about what to do when a patient goes into hospital. Can you imagine this? Your patient's about to be admitted who's on warfarin. So imagine a patient who's had a DVT, who's on warfarin, INRs are perfectly normal, everything's good, and they come into hospital who's a smoker, right? That's why he's had a DVT, but okay. He comes to the hospital for something totally unrelated to any of that, a broken toe, needs a surgical procedure, and predictably may bleed, unexpected bleeding. Why? Overnight, because they can't smoke in the hospital. This is not a nicotine effect. This is not nicotine that's doing it. This is the smoke that's doing it. So NRT is not going to help this. They come into hospital overnight, they're given NRT, and they start to bleed. And the bleeding is due to the fact that their warfarin is going up while they can't smoke. Bummer. And you can have that Can somebody grab that? Sorry. I think that's my 1 hour is up. I just wanted to say that these are important facts that you must think about. Some of you know the clozapine effect. Older GPs out there might know the theophylline effect. That was the same thing happening with theophylline, if you remember that. You needed to increase the dose of theophylline for a smoker, and if they stopped smoking, you had to decrease it. If you remember that, the same applies for many, many medications. The bummer we've got with our patients is they go into hospital and are absolutely not allowed to smoke. They're put on NRT in the hospital. That's taken care of. You adjust the dose and then they're discharged. So what about your patients on antipsychotics? You have to change the dose and then you have to change it again because buggers go home and smoke again. And that needs to be adjusted. You need to think this through, and hopefully you will. Okay.
Excellent. So that's the page of our learning outcomes again. Our hour is just about up. There's one thing that I think is important. Someone is just confirming a clarification that nicotine replacement is safe in pregnancy. It is safe in pregnancy and is recommended, and it's much safer than smoking in pregnancy too.
Yes. I see I have a colleague online who's Karen Counter, wonderful GP. Karen probably doesn't mind me mentioning her name because I know her very well. And Karen has her own carbon monoxide meter and wouldn't live without one, I'm sure. Karen doesn't mind me saying that, and she's giving you some comments at the bottom. She's extremely adept at helping smokers quit smoking. Thank you, Karen.
I just wanted to also add, I've seen quite a few questions come through regarding pregnancy. We actually did a webinar earlier last year in August on smoking cessation in pregnancy, and there is a recording of that webinar on the RACGP website that you can go and view. It's not restricted, so hopefully if you've got more questions around that, that recording should be able to provide you with some answers. And that brings us tonight to the end of our webinar. I just want to say a huge thank you to Tim and Renee for joining us tonight. And I hope you all really enjoyed the session.
Thank you.
Thank you very much, Renee. Thank you very much, everyone. Have a good evening.